Today we will be discussing about the anti-tubercular drug. You know, tuberculosis is a very severe disease which is caused by Mycobacterium tuberculosis. This is one of the gram-negative bacteria that is prevailing in the environment, and that is transmitted through sneezing, coughing, and different contacts of food, fecus, everything. So this infection is caused by Mycobacterium tuberculosis and causes the cough, persistent fever, then weight loss, loss of appetite. Okay, and they are causing different immunity problem also. They are spreading throughout the body, and as well as they are infecting the lungs, different genital urinary problem, urinary tract, in the brain, meningitis, spinal cord, and bone infection can be there. So that disease can kill the human being slowly. So if the immunity decreases, along with HIV infection can be occurred. So this is the mycobacteria. There's a slow growing bacillus strep, that is a small bacillus strep or rod shaped bacteria, dormant form in macrophages, that can be available in the dormant forms in different species also. Now they kill 2 million people each year. Increased incidence due to the HIV associated mycobacteria also. If any person is having HIV infection, they can be infected by the tuberculosis very first. Prevalence of TB in Sri Lanka is 79 per 1 lakh population. Actually, this is a subtropical country where poverty is more, malnutrition is more, hygienic condition is not maintained. This type of infection can be there, and due to some immunity problem, this infection can be caused. 40 years ago, the drugs were developed, and these drugs now become too much resistance. That's why multi-drug resistant strains are also emerging. Different infectious mycobacterium tuberculosis strains are there, which are not killed by the normal tuberculosis drugs. So the anti-tuberculosis drug is categorized in two category. One is first line category, one is second line. So first line drug will be classified into isoniazid, rifampicin, ethambutol, and pyrazinamide. This is the most important drug. And another second line drug like clarithromycin, ciprofloxacin, capreomycin, cycloserine, kanamycin, amikacin, and streptomycin. If the drug is not treated by this first line drug, then we have to use the second line drug also. Now we are going to one by one isoniazid drug, that is shortly known as the INH, that actually acts only in the mycobacteria and interfere with the mycolic acid synthesis. Actually, what is mycolic acid? The bacterial cell wall of the mycobacterium is very rigid, and they are having a complex cell wall. They contains peptidoglycan and porin channel and another different mycobacterial component, which is very tough to treat, tough to kill by the different drugs, and that's why this they also contain mycolic acid, which is very rigid to break down. So that's why this microbacterial cell wall will be broken by this isoniazid. So they are chemically known as the isonicotinic acid hydrazide. They are containing a pyridine ring along with the CONH2 hydrazide moiety is there. Then they passes freely to the mammalian cell wall. So in case of pregnancy, if the mother is suffering from tuberculosis, they can contaminate their baby also. So that is very critical condition. Effective for intercellular organism, and bacteriostatic. This is bacteriostatic. That means if we use the drug, bacteria will be inhibited their growth, and resting condition. The drug will be in a resting condition, and after some time they will be having bactericidal nature, and the bacteria will be dying, or the multiplying organism will be died. Now we have to study about the synthesis of antitubercular drug also. Here you can see 4-picoline with the presence of oxalic acid or potassium permanganate. They are converted to isonicotinic acid. Next, with the ethanol and sulfuric acid, they are converted to ethyl isonicotinate. Then with hydrazine, they are converted to isonicotinic acid or isonicotinic hydrazide. Pyridine ring along with the CONH2, NH2 at the above, and pyridine ring which contains a 6-membered nitrogen containing heterocyclic moiety. Now their pharmacokinetics we will be studying. They are well absorbed from GIT. The fatty food and aluminum containing antacid may reduce absorption. The CSF penetration 20% of the plasma. Concentration with non-inflammatory meningitis. Penetrate well into caseous material. Excretion through urine. The isoniazid can make toxicity to the liver also. Now, the drug is metabolized by acetylation process, genetically determined. They will be acetylated in a two-way, slow acetylation and fast acetylation. At case of slow acetylation, the better response will be there. T-hub will be 3 hours. That means the drug will be working for a long time. But in the fast acetylation, T-hub is 1 hour. That means the drug will be absorbed or eliminated very fast. There are some adverse effects also like hepatotoxicity, and liver can be damaged. Elderly or slow acetylators more prone of this infection. Next, polyneuropathy, and this problem can be prevented by concurrent pyridoxine, rashes, acne, and hematological problem also be there, hemolytic anemia and GCPD deficiency. Like the person who is having glucose 6 phosphate dehydrogenase enzyme deficiency, they can be animated. These are the infection rashes. Now, anti-tubercular drug. Next, we are going to the rifampicin. The rifampicin is very important drug which inhibits bacterial DNA-dependent RNA polymerase. Actually, this is killing the RNA-dependent polymerase, which is helping in the bacterial protein synthesis. And this drug is bactericidal in nature. They are effective for the gram-positive and gram-negative bacteria. They kill intercellular organism of the bacteria also. This is the structure where you can see 3,4-methyl 1 piperazine. This is a piperazine moiety, and methyl group is there, and rifampicin. One pyridine molecule will be there, and one CH3CH2O and NHNH2 will be there. This is resistance, chemical modification of DNA dependent polymerase. If the bacteria gets resistant, their DNA dependent RNA polymerase will be modified, so the bacteria will not be killed by the rifampicin. The pharmacokinetics, they are very well absorbed from the GIT. CSF penetration is 10 to 40% plasma concentration with non-inflammatory meningitis. Matlab, if the meningitis is non-inflamed, small amount of drug can penetrate also the brain cell, and elimination through the hepatic and renal excretion. Now, rifampicin continues. They are having the rashes and thrombocytopenia, hepatotoxicity. These are the different adverse effects. Mild elevation of liver enzyme in case of this drug treatment. This is very common to patients. Now, for the urine discoloration, urine sweet tears will be discolorated.
Recording in progress. This meeting is being recorded.